Thank you very much, Claudia. How is the sound? Too loud? It's okay? It's a great pleasure to be here. And I'd like to thank you, Claudia, for the opportunity to show our work. And I'd like to thank Professor Graff, that probably is outside, for the opportunity to join this faculty. It's an honor to share a symposium with Professor Dickey. Nice to see you. My talk will be about HPA-axis activity relationship between stress and depression. I am a clinical researcher. I'm a psychiatrist. And so my focus is studying mental disorders in a clinician approach. And so I believe that mental disorders are brain disorders, but not only brain disorders like a stroke, for example, but a disorder that affects mainly the circuits. Mental disorders result from a complex genetic risk, factors, and development environment. And so, you know these two words that are quite similar, even in English, nature and nurture. And so you try to understand the relationship between the genetic risk or the vulnerability and the development of the environment factors that could affect a person to develop a mental disorder. As a psychiatrist, I should tell you that current treatments help just a few patients to get better. And so we need to improve our diagnostic and improve our treatment. But symposiums like these are quite important because in this kind of symposium you can understand better something like neurobiology, the etiology of the main mental disorders. And so you can include these research findings in daily practice. This is translation psychiatry. This is a quite important study published by Ron Kessler from Harvard, and his group is a multi-center study. Even from Victoria, Carmen, Vienna, took part in this study. And Ron Kessler and group demonstrate that most of the depressive patients are underdiagnosed and undertreated. And so in this sample, you can see that no more than 50% of the depressive patients receive treatment, and around 20% were really treated in a right way and receive a good outcome about this treatment. And so what you should do, if you are not treating, and if you are treating, you are not treating well these patients. You need to improve, first of all, the diagnostic of these patients. Second, you need to understand how to approach these patients, which are the best treatment for each patient. I think it was 3 weeks ago, Professor Graff, or around that, received Tony Clear, Professor Dickey here. We talked in the same place here, and we're talking about how to improve the treatment of depressive patients and how to treat more people in the right way. And so this is quite difficult because we know that there are several factors that could influence this treatment. And before I moved to London, I spent around a year and more than that in Maastricht, the Netherlands. And I had a collaboration with Professor Van Praag. And in this very nice review, he states very important fundamentals about how stress can cause depression. And another very important series of study, Bob Post tried to understand how the stressor sensitization could be a precipitant episode of affective disorders like depression and bipolar, and how in the course of the illness, spontaneous episodes could start without a stressor, like in the first episodes. And so this is two different paradigms, but both are related with depression. And so to put more neurobiology, you should understand a little bit more about how HPA axis and stress could be a model to understand and to treat better patients with depression. You know that stress is like something that could be quite important in this HPA axis, in these hormones from the hypothalamus, pituitary, and adrenal gland, releasing cortisol. In this model, you can see that high levels of cortisol could be released in the blood circulation. And this cortisol, that is our endogenous corticoid, could bind, could link with different receptors, mainly GR receptors and GR and MR receptors in a specific site that is hippocampus. I will talk a little bit later and more deeply about these two receptors. I like very much this model. This model is a theory, and so like a Dick and Grave theory help us to understand better how the function of these receptors. And so the theory is about the intensity. And so you have stressor intensity, and so a new environment for people that are coming from, I could imagine the Blanchard couple that are coming from Hawaii. How different is and how long is the trip? And so it's a new environment, even if it's not the first time that they come to Brazil, but it includes a little bit the release of corticoid, like cortisol. And so in these low levels of stressor, it could activate the MR receptors, first of all. After that, if you have a repeat or a chronic stress, you are not only activating the MR receptors, but higher levels of stress could activate as well the GR receptors that are less sensitivity to low levels of cortisol. These two receptors could help us to understand a little bit about cognitive function as well. And this very nice model try to explain a little bit as well. If you increase the levels of glucocorticoids like cortisol, you have this U shape here to understand how it could improve the cognitive performance or decrease the cognitive performance, like a cognitive dysfunction. And so low levels of corticoids could just occupy part of the MR receptors, and so you don't have a very good cognitive performance. But if you increase a little bit the stress and then increase a little bit, of course, in optimal levels, genetic, early environment, and other optimal levels, you occupy whole MR receptors, and so you have the high cognitive performance. But if you are really stressed, you are not sleeping well, you are not eating well, you are depressed, and so you have high levels of cortisol. For example, you have the occupancy of these two receptors, and then you decrease your cognitive function. So the cortisol levels in both receptors, you have an optimal level. If you have high levels, it could be a decrease of cognitive function. The opposite is the same. This is a very nice graphic that I think is the main message that I would like to give you today. If you get this message, I can stop here. And then you can have another coffee break, maybe. And so you can see here acute stress. And then you have the relative serotonin response. If you have, for example, 100% of serotonin function, this is, of course, a topic, but 100%, and then you have acute stress. And so you can see the serotonin function is decreasing. And then, how to compensate this, how to fulfill and how the feedback of the good stress could improve again the serotonin function. You can see, first of all, the MAR receptors helps to improve the serotonin function, and then with a little help from my friends, GR receptors, then you become around 80% of serotonin function. But this is healthy volunteers example. If you have a patient with depressed chronic episodes, what happens? This patient with severe depression already start with 20-30% of serotonin function. We see a lot of SSRI, for example, decrease fertile and other things like you saw before, and decrease the cognitive function, and then with a lot of treatment, psychotherapy, antidepressant, you can see it goes no more than 40% of the serotonin function, even with the help and the binds of the feedback with MR and GR receptors. And so the link between these two receptors, the link between the release of hormone stress is quite related to, or closely related to serotonin function. Another issue that I would like to mention here is something that happens a lot in patients with depression, mainly bipolar depression, comorbidity like Pedro will talk later about drug dependence and borderline patterns. And so you have the impulsivity measures, at least three different impulsivity measures: motor impulsivity, premature response, and a delay in discontinuing. And so if you have a decrease in serotonin levels, you have an increase in premature response. And the opposite is true. If you have an increase in serotonin levels, you have a decrease in premature response and a delay in discontinuing this impulsivity. And so this is, of course, is related with the pleasure and with the dopamine circuits. A very nice study that I just saw yesterday night, I should tell you, tell a little bit about the serotonin metabolism that is increased in the very beginning with stress and with the sustained stress that will lead a decrease in the serotonin turnover. Mainly the 5-HT1 receptor system respond in these two phases. First with increase, and after that with a decrease in the sensitivity. The impact of the stress and the duration of itself also affect the 5-HT2 receptor system. And in the very beginning, it was a downregulation, and after that, you have a binding that increase with the stress, the 5-HT receptor binding. And so you can understand a little bit about the relation between some hormones in the HPA axis and the interactions of serotonin circuits and system. But in clinical practice, it's not easy because you have paradoxical response. For example, you are talking about depression. And you can see in this graphic at least 3 different types of depression. Melancholic depression, that is the most classic and the most studied subtype of depression with the increase of HPA axis. Atypical depression, this have some vegetative patterns in the opposite of melancholic. For example, increase of carbohydrates, oversleeping. Winter depression, quite common in high latitudes, and chronic fatigue syndrome is subtypes of or patterns of depression. And here you have a decrease in HPA axis. And so even the same disorder could have different patterns in the HPA axis. And of course, this is related with these 2 main receptors. If you have an increase in the activity of GR receptors, you can have melancholic depression. And here again we have the U-shape, trying to have these groups of hyperactivity of the HPA axis and this group of disorders with hyperactivity in the opposite cortisol release or CRH release or ACTH release, different hormones of the HPA axis. Based on these, several different groups of researchers from different parts of the world have proposed that you already have some data to change the next psychiatric classifications, including not only the phenomenological system. I know that there's a lot of psychologists here, maybe some psychiatrists as well, but to assess psychiatric symptoms in depression, you mainly use for the American classification, the DSM-5 and the ICD-11, the WHO classification, phenomenological symptoms. And the proposal of some groups is that you already have enough data for some disorders, for example, melancholic depression, to include some markers and some tests that could assess, like, for example, hypothyroid or something related with different other disorders. For example, nighttime cortisol levels could help us to improve the diagnostic of these patients. Tony Clear and I wrote this other study that you compare atypical depression, winter depression, that is seasonal affective disorder, and chronic fatigue syndrome. You can see here the measure of salivary cortisol between 6 a.m. to 9 p.m. And you see clearly here that the salivary cortisol in these measures are quite low than healthy controls. And you can see the same in atypical depression. You can see the HPA axis are in a different pattern with the high levels of cortisol in melancholic depression, for example. And so this is a different way to approach these patients and try to improve the diagnostic and then the prognostic of the treatment of depression. And so to summarize this first part of my talk, I like to underline some points. For example, stressors activate sympathetic and HPA axis system. Glucocorticoids regulate stress response through two different receptors that are in balance. You could not understand one without other. I'm from the South, and we have two important teams in the South. Inter de Porto Alegre, champion of everything, and the other one that we will lose to Palmeiras tonight. And so we have these two teams. But to understand one, you have to understand the other. This is a balance between the two, like you have the balance between MR and GR. And if you have a chronic stress, a prolonged stress, physiological problems in endocrine function will reflect this. Of course, there is a vulnerability. You have individual vulnerability. It's not all people, all persons that suffer from chronic stress that will have this response. And let's move on to treatment. And so let's see a little bit about the relationship between the course of depression and the treatment that could reflect in HPX system. The group of Florian Rosbauer in the Max Planck Institute developed several studies trying to understand how to improve the outcome and how to predict this outcome. And in depressive episode, HPX is hyperactivity normalized along treatment. This is a predictive, without astrology, without different kinds of prediction. Just assessing the HPX, you could understand how a patient could be a responder to a treatment or how a patient could be resistant to a treatment. And some tests like Beck's CRF suppression test lies more in predictive then diagnostic properties. This is quite important because most of the researchers in the 80s and even in the 90s are trying to use this kind of dexamethasone suppression test and others as diagnostic tests. But they are not diagnostics. They could predict the response, and they could see before the normalization and before the psychopathology changing of these depressive patients happens. And so they are really good for this assessment of the outcome of these patients. And this is a very nice graphic that shows the progress of the depression and the symptomatic. And so you could imagine here a very severe depressive patients. Actually, you could imagine two very severe depressive patients. In the same level, if you assess them with psychometric, for example, Hamilton, Beck Depression Inventory, they have very high levels. One with low activity of the HPA axis, and the other one with high activity of the HPA axis. And here, with the same psychological symptoms, you can say that 16 weeks, 4 months after, these patients could probably have a remission if they have a melancholic depression. And the other one, with high activity, with the HPA axis, with melancholic pattern, you have a relapse, and probably this patient will be resistant to treatment, and then you can see this in the chart of his life or her life. This is another study that you try to understand a little bit about the treatment. And you can see, talking about tricyclics, clomipramine is one of the most strongest tricycle antidepressants that you have. In this study that used 4 different corticoids, you can reduce, of course it's a in vitro study, but you can reduce GR function just in healthy volunteers. In severe depressive patients, one of our most strongest antidepressant could not change the GR function. Another way to approach this to understand is using the neuroimaging. So, you know, for example, the volume of structural changes that you can see in depression. In blue, you can see the decrease of main of this area, the volume in chronic depressive patients. And so you can say that depression could decrease the size, the volume of areas like amygdala, for example, prefrontal cortex and others. And as well, you can see changes in the function. You can see an increase in amygdala function. Decrease the size, but increase the activity. Paradoxical, but like depression, neuroimaging shows some of these paradoxical results. And this is a very nice study from the group of Siegfried Kasper from Vienna, showing in a PET neuroimaging imaging 3 different receptor binding, 5-HT1A receptor, 5-HT2A receptor binding, and the serotonin transporter binding, showing the high levels of protein bindings in some areas and the low binding in some other areas in depressive patients. What is important for treatment? As a clinician, I could tell you that, for example, again, you can predict if a patient will be resistant to treatment or will respond to the approach that you are giving to these patients. For example, if you can assess the serotonin transporter availability in the alpha nuclei, for example. And so in a clinical trial, you try to measure this in a PET scan study, and before patients start the treatment with SSRI, you can measure the serotonin transporter availability, and you can predict, for example, this is a study that I think is already in press, but I'm not sure. But, and so you can consider submitted the decrease in the Hamilton Depression Scale 28 days after treatment, and so you have the levels of serotonin transporter. And you can see, if you are closer here in blue, the lowest level of serotonin transporter have there are no responders. And so a good experiment correlation here. And so before treatment, 18 patients with major depression, you can use a transporter of serotonin as a predictor of response. Moving to genetics, you have another important issue to assess in this kind of patients. This is a classical study from Avshalom Caspi, published in Science 2003. Most of you already know this study, just to underline the influence of stress on depression moderation, again, with the polymorphism of serotonin transporter. And you already know that some of these patients that receive severe maltreatment, we are developing several studies here, start with Professor Greff, assessing resistant depressive patients, and you saw in our sample a severe sample with maltreatment. We haven't assessed yet the genetic, but we collect the data maybe later. And you can see if they have long homozygotic serotonin transporter, even if they receive abuse, maltreatment, neglect, they will not increase the probability of a depression episode. On the other hand, if they receive the same severe maltreatment, but they have the vulnerability with the short alleles of the serotonin transporter, they increase a lot of the depression episode probability. I think this paper from Christine Hein and Charlie Nemiroff already summarize the idea of this point. We know there is a vulnerability, like we saw polymorphism. You should mention that females increase as well this vulnerability. If these patients have early life stress, and so they could develop alterations in the phenotype of the central nervous system. And if this trauma, if this stress, early life stress, persists as a chronic stress, of course, without treatment, without social support, these patients will develop depression, anxiety, and you can measure the level of this in the endocrine and autonomic measures, like we are talking about HPXs and serotonin, for example. I'm considered an old researcher. I started with Professor Pedro Lima here and Professor Helena Khalil almost 20 years ago. Then we published one of our papers trying to measure using a monoamine oxidase inhibitor, moclobemide, and measuring the effect in prolactin levels. This was in the 90s, probably Professor Dickin known, moclobemide, that is out of the market because it's not working. And we demonstrate here that if you give a single dose, it could not increase after 4 weeks the levels of prolactin, probably because it was not increasing the levels of serotonin receptors. We already know that other kind of treatments like corticosteroid could increase and change serotonin receptors and could increase depression, could give in some vulnerability patients euphoria, mood lability, and as you saw, cognitive impairment and psychosis. And in this very new study, you can see that glucocorticoid treatment could increase the density of serotonin 5-HT. So, what's happened? Yeah, I will not give another talk, but maybe you can, yeah. A little bit, yeah. This one. Yeah. Obrigado. I was talking about glucocorticoid treatment that increase density of serotonin receptor in humans. And so you can see clearly that after some period of glucocorticoid treatment with prednisolone, you can see a higher level of serotonin density, mainly 5-HT2A receptors in men and women as well. And so you cannot see a very big difference between the gender. And to summarize again, I should tell you that receptor theory of mood disorder, you can see a reducing GR expression, you can see an increase in CRH synthesis, and changes in other hormones of the HPA axis. And the main point is that these are linked with changes in noradrenergic neurotransmission and mainly in serotonergic neurotransmission. And this increase, for example, will have cognitive effects, neuropsychological effects. As I demonstrated, it blunted not only the HPA axis, if you have an increase in cortisol levels, desensitization in 5-HT1 receptor, and so you have alterations in HPA axis, prolactin response, and this is like Niagara Falls, or better, Iguazu Falls. This is another summary of the HPA axis and the links with Hafi nucleus. Serotonin could decrease the GR bindings in these hippocampus, and so could maybe helps to decrease the stress situations. And on the other hand, you can see an increase of locus ceruleus activity that will increase GR bindings, and so it will keep the circuit overactivated. Of course, you have GABA and other influences. In the last part of my talk, I would like to mention some of our studies related to different steroids and receptor functions selectivity in MR and GR. And so here you can see our main cortisol, our main corticoid, that are in the middle of the selectivity of MR and GR. Most of the studies have been done with dexamethasone, that is really more selective to GR receptors. We developed a test that's called Prednisolone suppression test that is not really like cortisol, but is much closer, as you can see. And you are quite interesting to assess, because most of the study just assess this area here, the GR receptors. And so we're studying MR function in the stress and depression with fludrocortisone, a selective agonist of MR. You have demonstrated that dexamethasone is really different from cortisol in some of our studies. Prednisolone is much closer bind to MR and GR in closer way like cortisol, that have almost the same half-life of cortisol, prednisolone, and binds to other proteins like CBG, for example. In this study, you can predict, as I demonstrated with this test, in patients with depression, they stay almost around 3 to 4 months in the same inpatient unit. And using a placebo in the first week, you cannot differentiate between no responders and responders. But when you use prednisolone, just 5 milligrams in the first week of admission, you can predict if these patients will respond after 3 or 4 months of treatment in an inpatient ward. And you can see that actually these patients that are considered in the national health system in UK as no responders, they still no responders. But some of them are considered treatment-resistant depression, and they respond like, have the same level of cortisol like controls. And so here the same, when you give placebo and measure salivary cortisol at 9 a.m., 12 and 5 p.m., you could not differentiate after placebo, but you can see a big difference in no responders with higher levels of cortisol and responders that suppress, and so the HPA axis is preserved. And so you developed this test. This is a novel tool to assess both receptors, because prednisolone is a mixed agonist to GR and MR, It's already been tested in depression, resistant depression, chronic fatigue syndrome. You are trying to assess them in patients not only with depression, but with a history of early life stress, maltreatment, abuse, neglect as well. Because most of the study are just assessing this function in this kind of patients. And even in this kind of patient, you have contradictory and opposite results. Here, the gender is quite important. You can see cortisol and ACTH decrease in women with depression, with early life stress, and cortisol and ACTH increase in men with depression and early life stress with the same test. And you have several others opposite and contradictory results in this area. So we developed a test, a study, when we did the psychometric assessment for inclusion, 5 to 7 days after inclusion endocrine assessment. And you try to measure not only blood, but salivary cortisol, as I will demonstrate later. And you can see 60 days after inclusion, the patients are in a severe inclusion, Hamilton over 17 in this beginning. And you did a psychometric and endocrine assessment in these patients. And in our preliminary data with 45 patients, we found quite interesting results. This study was done in the day hospital here in the unit of psychiatry, in 2 other units in the 3rd floor of the Hospital das Clínicas. 70% of these depressive patients have a history of severe early life stress. Just around 30% without. And this is amazing because these patients with early life stress have a very high levels of suicide attempts, almost 6 times odds ratio, 5.8 more risk to develop suicide attempt if they have a history of early life stress. And then we split the sample in 2 other groups, the groups with response to treatment, if they measure the severity of depression on admission and on discharge, more than 50%, and so you consider they are responder to treatment, and most of the patients are not response, as you can see here, because they don't respond at least 50% in the Hamilton Depression Scale. And you can see that these patients that are no responders, around 80% of them have a history of early life stress, with a very strong history of sexual abuse, physical abuse, emotional abuse, and some kinds of neglect as well. If you measure the 2 groups with early life stress and without early life stress on admission and 60 days after, you can see the patients without early life stress have a much better outcome measuring the Hamilton Depression Scale and with another depression scale, Montgomery-Åsberg Depression Rating Scale. But I think these are the most interesting data when you compare with the Beck Suicide Inventory on admission. They have moderate to severe suicide ideation. 60 days after, these patients improve a lot without early life stress. They are almost around 1 or 0, the mean regarding suicide ideation. But the patients with early life stress is still in a very high level of suicide ideation. And so you assess the endocrine of these patients using placebo, fludrocortisone, MR agonist, prednisolone as a mixed MR and GR agonist, and dexamethasone as a GR agonist a day before. And then you measure the cortisol at night, and then when they wake, 30 and 60 minutes after. And at 9 o'clock, you measure again the salivary cortisol and some other hormones like ACTH, vasopressin, and DHAS, and compare these in the 2 moments. I will show you just preliminary data about this these points. And so you measure the salivary cortisol in these points. And here you have some data. I think to summarize the data, you can see here in red, no responders. And so no responders after a MR agonist that is fludrocortisone, they do not suppress. As you can see, a mixed MR and GR agonist, prednisolone, you have a little bit suppression, but it's quite different from responders as well. And if you use GR agonist, dexamethasone, you can see no difference between responder and no responders. And when you split the sample in with early life stress and without early life stress, you can see a different pattern. But you can see a difference that patients with early life stress have different suppression comparing with without early life stress regarding MR agonist suppression test. And you can see here again with early life stress suppressed in a mixed agonist MR and GR. And here, without early life stress, have a different pattern when the GR is linked. And so to conclude and summarize this data, I would like to tell you that these studies demonstrate that early life stress leads to permanent changes in the HPA axis. And so people, teenagers that suffer from this kind of early life stress have permanent changes when they are adults. And this could be reflected in the HPA axis function and could lead to develop depression in adults. And these findings suggest that the dysregulation HPA axis is partially related to an imbalance between GR and MR. It's not only GR, it's not only MR. It's not only Corinthians, it's not only Palmeiras, it's not only Inter, it's not only Grêmio, it's not only Manchester City or Manchester United. You need both to have a game. And MR function is fundamental to response treatment in depressive patients and early life stress and in patients in this sample that we found with hypocortisolism, high levels of personality disorders and high levels of early life stress. This is a classical study to finish that Richard McCade and Alan Young proposed that the future therapeutic targets in mood disorders are the GR receptors. It was written and published in the year 2000. We should add that not only the GR, but the MR as well are quite important targets for mood disorders treatment. And this is not future. This is real. When I was young, as some of you, I started to study psychopharmacology in Professor Graf's book. Now I'm here studying in this group, in this university. And so we are trying to understand how improve the stress response in bipolar, for example, in affective disorder. You can use spironolactone, for example, antagonist of receptor function. Of course, this is just a case series, but you can decrease the stress in this kind of patient. But this is a not controlled study. When you publish this year, this preliminary communication about plasma cortisol in another sample with bipolar patients that have a different pattern of mood disorder. And these are the first episode in drug-naive mania, different levels in euphoric versus irritable mood. This is the same novel. This is the same soap opera. You saw the difference between melancholic and atypical depression. Now we're seeing the difference between euphoric, bipolar, and irritable bipolar. When you compare with healthy controls, you have low levels of cortisol and quite interesting data that elevate mood. You cannot see here, but it's cortisol here and here. High levels of cortisol, you have low levels of mood. High levels of cortisol, you have high levels of irritability, and you have this correlation, negative correlation between these two symptoms, irritability and elevated mood. And this could be marked by cortisol. I'd like to thank Claudia again for the opportunity to be here, Professor Greff for the opportunity to work and do research in this university, and to our group here, our researcher group, some of my PhD students, my master science students, Professor Andrew, Carne Pariante, Professor Tony Clear, Professor Greff, and for your attention. Thank you very much.